This is the International Academy for Clinical Hematology around the globe and across the hematology field. It is 10 a.m. in Calgary, 5 p.m. in Cardiff, 6 p.m. in Paris. And it is my great pleasure and honor to welcome you all to this new educational activity as part of the ICH for Nurses series. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And I'm very pleased to be joined today by two distinguished faculty, namely by alphabetical order, Mrs. Anna Giulione from the Calgary Comprehensive Cancer Center in Canada, and Mrs. Emma Williams from Cardiff in the UK. And both of them are experienced clinical research nurses with a special focus on multiple myeloma. And we thought for today's webinar to address some of the latest innovations in the field of multiple myeloma. And as you probably know, this is because we had recently, at the end of September 2024, the 20th annual meeting of the International Myeloma Society, which was held in Rio de Janeiro in Brazil. And during this meeting, we've seen the release of some novel and exciting new data, which are very relevant to the daily clinical practice. And we had the opportunity, as part of the ICH activities, to have a few days ago a roundtable debate among the physicians dedicated to the take-home messages from this 20th IMS annual meeting. And today, the goal is to get the patient, the nurses' perspective and the take-home messages from a nursing perspective from this IMS meeting. So, Emma, Anna, thank you for joining us. And despite a very busy day, I really appreciate the time you're dedicating to the ICH activities. So I'll try to structure this discussion around a few topics, maybe the frontline treatment of elderly myeloma. And of course, this is a very hot and exciting topic because we're hearing since the last 6 months or so a lot about the role of quadruplets in the treatment of the so-called elderly or non-transplant eligible, or those patients who don't wish to proceed to an autologous stem cell transplant. And thanks to the so-called benefit trial by the IFM, thanks to the IMROSE trial, an international cooperative trial, we know that the combination of isatuximab, bortezomib, lenalidomide, and dexamethasone has been approved recently by FDA for the frontline treatment of patient with elderly myeloma non-eligible to transplant. And during IMS, we've seen the release of the first results of the so-called CEPHEUS trial, also showing the role of quadruplet with daratumumab VRd in this population. And of course, the big debate in this field is about how to select the so-called fit patient, because obviously We've lived for the last few years with the triplet combination, daratumumab, lenalidomide, dexamethasone, thanks to the Maya trial. And now we're adding actually bortezomib, a proteasome inhibitor, to this combination, ending up with an anti-CD38 and VRD. So I don't know who wants to start. So ladies, please feel free to jump in whenever you're ready. How in your daily practice as research nurses, how do you handle this categorization between fit, unfit, frail, unfrail? I know there are plenty of scoring systems, but I guess there is also the nurse experience. So I would love, and our audience would love to hear from you. And by the way, guys, this is a live webinar, and you are more than welcome to jump in and send your questions to Emma and Anna, and I'll do my best to share them. So who wants to start?
I could start.
Yes,
Yeah.
by alphabetical order. Let's do it like
Okay.
this. Anna.
I think when we're deciding, especially if it's patients at their first line of treatment and we're giving DVRD, DARA with Velcade and lenalidomide index, we look at the comorbidities. We see how old the patient is, how active the patient is. Do they live alone? Do they need extra support? And then once they start the treatment, we have our baseline. We just like to see what's happening from that baseline. Are they getting worse? Do they need more support? Do they need more home care, for example? Are they asking their family members for more help? So it's just things like that that we keep an eye on. And their appetite, big thing. Whether they're losing weight, whether we need to get a dietitian involved. So these are the factors that we look at when well, in our area anyway.
Yeah.
I don't know if it's the same for you, Emma.
Definitely, yeah. Almost there's an added expectation to look at frailty within this when you're doing the screening assessments. You know, it's almost like an extra layer of just looking after the patient and making sure that they're not going to, you know, suffer with side effects from the outset, really, isn't it?
Correct.
And it takes a lot of our time in making sure that that process is followed through when they come to clinic and come for their research appointments. So yeah, it's crucial. But we know our patients very well, and we get to know them really well and form a good relationship. And I think as research nurses, they're very often more honest with us
Yeah, I agree.
than other people.
Yes. Mm-hmm. Yeah. And I forgot to mention transportation is always a big issue. How many
Yes.
appointments they have to go, can they do some of the labs closer to home, or can we do have mobile lab for a certain age group and frailty, so we can send the mobile lab to the house to draw some blood for us, so that's helpful
Good. Yeah.
as well. But it's not everywhere in Alberta. It's just specific areas. So we are lucky we have that. And so that frailty score helps me to get that lab to the house, for example,
Yeah,
as one of the
very
resources that we can use.
that's very
But
good,
yeah,
isn't it?
yeah, and the transportation is always a big issue. Oh, I
Yeah.
don't feel like coming, or I don't feel up to it, and yeah.
Yeah.
So yes,
Sorry.
please. No, please, Emma.
So very often, some of our patients on trial who are getting more elderly, will prefer to travel alone,
Mhm.
so that they don't want to put anyone out,
Mm,
and it can be such a journey, you know. So 4 or 5 times getting on and off transport, it can be
yeah,
really difficult for them, but
mhm,
they persevere.
So
they
we
do.
have a
Mhm.
question here from the audience about the role of the social environment of a given patient in your overall assessment of fragility or frailty. Do you consider, and I can give an example, for instance, assuming you have a widow who is isolated in a remote village, whether in Alberta, which is a huge state, or somewhere in the countryside in beautiful Wales. Is this something that you take into account? Because obviously some of the treatment may have complications and you need to have someone supporting or assisting you, or not too far. How is this handled?
It's just being really, really honest with the patient. You know, none of these treatments are without side effects. And it's just being very honest and very open, and the informed consent process is being very robust from the outset, so that you're not giving them false information or trying to, you know, sway any decision. You have to be honest, because it is a treatment that they will stay on, you know, long term, a lot of people. So, and generally we do have those conversations with our patients, and they do form a decision because we very often we know them very well. So yeah, it's generally very well managed, I would say.
Yeah, and even the ones that are in remote areas, we always hook up with their community services, so that we let them know, because now we're on a new IT system where all of Alberta has access to the same to the patients. So I can connect with let's say a community nurse that is 100 kilometers away from our center, and let her know, because I have a patient now, and I let her know the patient started a new trial and this is some of the side effects, if you see anything. And we always give a patient like a card, an emergency information card. So it has the name of the trial, the name of the drugs, the name of the doctor, for the example, Dr. Bayless is one of our primary investigators, so his name will be on there, the phone number, so that they have this information if they go to an emergency room, if they go to their family doctor and they're not feeling well.
Yeah, I think it's important as well not to give them too much too soon.
Yes.
You know, a lot of patients come in and they handed over almost like a goodie bag of all sorts of information. But our elderly patients, you know, they want it in stages, and they want it. They very much guide us as to when we give it, but just snippets almost of information, so that they have their time to get their head around things, I think is an easier approach.
So we have a question here about the role of telehealth, which I think expanded and has been developed a lot since the COVID-19 pandemic. Is this something that is proving to be helpful and actually is contributing to whether one would consider that a patient is more likely to be eligible maybe to a more effective, potentially more toxic, I would say, therapy, if we have access of good monitoring through telehealth? Any thoughts on this? Any experience, Emma?
I think it does have its place, definitely, especially for an elderly cohort of patients who struggle to get in. But we have to remember why we do these trials. Ultimately we have to conduct safety assessments, and we have to do that very often face to face to get a full overall picture of the patient, which we can't always get via a video link. But yeah, I mean, sort of definitely have their place in sort of more straightforward consultations. And that does keep the patient sort of reassured and in a happier space, I think.
Yeah, I agree. I agree with that, with Emma. I like to see the patient. I like to see them walk. I like to see how they're walking. Are they the same? And sometimes a video chat, it's good for a quick assessment, but I think I know at our center we don't use the telehealth for the clinical trial patients. But our patients do have our numbers. So they have all of the nurses' phone numbers. So there's a lot of phone calls. They call us all the time. So that in that respect, they feel that one-on-one, they have someone to connect with, that they feel a little more safer and on how to deal with those side effects as well.
I think the other thing that we have is we have a designated myeloma phone for all of our patients on trial, and very often, you know, that they'll just send a text message. Can you advise on this certain thing? It might be to do with an injection that they might need to have, and they just want to check it with the clinical team. So that does assist us as well, and sort of you know, helps the agenda with the patient, I think, which has been quite helpful post-COVID.
What about the scenario? I think a member of the audience is raising an interesting scenario. Is at time of diagnosis, patient may be suffering from some severe symptoms, and they may appear, the first time we see them, as being frail and weak, and they cannot tolerate a treatment. And then you start a sort of a gentle treatment, and of course things will improve, and then you realize actually this patient actually has no comorbidities and was mainly struggling with the symptoms of the disease. Let's say, you know, the famous CRAB criteria: hypercalcemia, kidney dysfunction, anemia, bone pain. So do you consider, from your perspective, that such scenario would allow us actually to switch some patient to these highly effective quadruplets? Because why we are currently debating the issue of quadruplets, because if you consider, because we have these data and there is a median follow-up of more than 5 years now in the IMROS trial, the extrapolated or expected progression-free survival is quite impressive, more than 90 months. Which means if you have a patient who is 75 today and going into this kind of treatment, actually probably this patient will receive only one line of treatment and no need for other treatment. So what are your thoughts on this, Emma?
Can you maybe go to Anna while I just formulate what I would like to say?
Yeah, you know, I was just thinking when you were saying all that, it depends also what's available in your country or in your city, even, because not everybody has the same treatments available to them. And I think when we start off, frailty is one of the things we look at. But if we have the DARA that is available for all patients that are not eligible for transplant, that's what we're going to give. And then we treat the symptoms as they come, because that's the best thing we have to give to the patient.
Well, obviously, I do agree with you that at the end of the day, availability of drugs, reimbursement status is crucial. And I know that in many places across the globe, we're struggling with this because innovation has a cost. And obviously, we've seen tremendous, amazing progresses, and our health systems are not able actually to follow the pace of innovation. But the good news is, at the end of the day, these drugs will become available at some point to all patients. And we at the ICH, by the way, I like to insist, we really advocate for the availability, accessibility, and affordability of all of these life-saving drugs. So anyway, your thoughts, Emma, on this?
It's just I've lost the trail of the question now. Sorry, Mohamad.
The question is whether, in your experience, someone who has a diagnosis appears to be weak and frail, do you think that after a few courses of treatment and patients are improving, actually we may be able to switch to a more intensive and go, for instance, to the
Yeah,
quadruplet regimens?
yeah,
Just
yeah.
looking to your perspective on this.
So I think with our patients, with any of our patients, we're very flexible with treatment options and the treatment availability. We never like to say that we're going to stick to this and that is it. And you know, there is always that flexibility when we're having the conversation with our patients every time they come to clinic. They must always realize that they're in the driving seat, and they can change at any time as well. So we kind of keep that quite flexible in our discussions, in that, you know, we could switch at any time for any possible reason, really. And just re-emphasize that at almost every visit, so that the patient is informed, and so that we are aware if there are any changes, that we could move quite quickly to a different treatment.
Okay,
Hope
wonderful.
that
So,
answers your question.
no,
So you
absolutely.
see,
No, I think that
our,
there's
our
no right or
patient,
wrong answer,
no,
actually.
and
It's how we approach these patients.
yeah, and our patients have to progress before they change to another treatment. So you have to stay on that treatment until you progress, and then you move on to the next treatment.
So we have another question from the audience, whether today, in your experience, patients who are receiving quadruplet regimens, or what is supposed to be a sort of a intensive regimen, what are the main questions patients are asking you, actually? You know, imagine, let me give you a scenario. They come to me and I say, hey, this is what you have, and I'm going to give you 4 drugs: an anti-CD38 monoclonal antibody, bortezomib, I'll give you an IMiD, I'll give you dexamethasone, and then I know they spend 15 minutes with me, and they're going to spend 1 hour with you, ladies. So, so what kind of questions do you expect, do you hear, do you see from these patients in general?
I think a lot of it with them that we see is to do with timings and just the sheer volume of drugs and medications that they need to take. The scheduling is really challenging for some patients. And with some studies, they give you know, schedules that we can follow, or we can devise our own. But they all have their complexities, and I think they're quite a challenge for our patients. So we spend a lot of time in trying to break that down and try and make it easier for them.
Yeah.
Anna, any tricks from Canada?
The main question I get is, how long do I have to take these drugs? And how will it affect my social life? Because a lot of them, especially if they're elderly, I remember one patient was 70 something and said to me, well, how long do you expect me to live? And it's like, well, that's not up to me. But I got her question. I understood why she was asking that question. We're giving them all these drugs to keep them alive, but the side effects can affect their quality of life. So they want to make sure that they will have some sort of quality of life as well. So that question of how long, I get that all the time.
I think as well, there are some challenges with all the ancillary medications that they have to take alongside everything. So they can go from you know, being on a few tablets to it just being totally overwhelming to them, that they have to take then anti-sickness to counteract this, and something to counteract another, and it can be it can be a real challenge for them.
Yeah.
Okay, so let me now jump into the practical modalities, and this is your daily practice as nurses, about the way you use and you administer all of these novel combinations. Obviously, we have the oral drugs, and here you play a major role, and you mentioned explaining, educating on when to take this pill, try avoiding, you know, missing this. So this is for the oral ones, for instance, like lenalidomide, which is an oral drug, so dexamethasone also. Bortezomib is given subcut, and I think it has been used now for almost 25 years, so in general. So when it comes to the antibodies, we have the IV formulation, we have the subcut, but soon there will be the so-called on-body delivery system, which is a sort of a device, I would say, designed, it's a wearable bolus injector
Mhm.
that is applied to the abdomen by a healthcare professional, and it administers subcute drugs like acetoxumab or other drugs, because you can apply the technology to whatever you want. So how do you handle? What is your experience as nurses? Any preferences in? I mean, I personally like this OBDS story, like putting the device and then let it go. But what's your current experience? Because we always claim in congresses that subcute is fantastic. I can tell you some of my nurses are really complaining of subcute, because when you are a nurse in the day hospital and you have to give 10 or 12 patients, subcutes, you end up at the end of the day, your fingers are tired. So any thoughts on this, guy?
I think
We,
oh, sorry, go on,
oops.
Anna.
We actually have a program where we give the bortezomib subQ. The patients give it to themselves at home. So they have to, there's a teaching, same thing with the IVIG, where they give it to themselves at home. So we started this program, I'd say about three or 4 years ago. And some of our patients actually like giving the bortezomib to themselves at home, because it's one less appointment to the hospital or our day clinic. The other one is when we have, like, let's say Dara and bortezomib, we give them on the same day so they don't have to come back twice. So we try to schedule things around the same time just to help. But yes, your finger gets tired, but you try to spread it out amongst all the nurses in the clinic, so that not one person is giving more than 2 or 3 a day of the Dara, for example, because that's the harder one to give.
What's your experience, Emma?
So given, we give all sorts of agents, in a chemotherapy setting, as you can imagine. But it's consideration of very frail patients who are very underweight. This can be an issue, where they have barely any fat to sort of put the needle into, even though it's a small needle. And they can bruise easily, and have sort of reactions around the site. So it can be challenging, even though we say it's a small injection, and it's it's easy in and out of day unit very easily. But again, quality of life can be impacted because of them. It's not always as straightforward as it seems.
Mm-hmm.
Excellent. Thank you so much. Let's move now to the relapse setting, because it keeps on moving. New options are becoming available for those patients whose disease is relapsing. And actually, the key word, I think, the champion, is immunotherapy. And immunotherapy comes with different flavors. So we have CAR T cells, cellular therapies, and obviously these cellular therapies are rather limited these days to some university hospitals, big academic center. So accessibility is not easy. So I will not discuss them today. But on the other hand, we have two forms of immune therapies, the antibody drug conjugates, and we heard at the last IMS some exciting new positive data related to belantamab, which is a sort of a very nice, fancy, I would say, a new form of delivering chemotherapy, actually, because it's an antibody, but you're using a linker, which is a toxin, which would enter the cell and kill it. But also we have the biggest, the superstar these days of immunotherapy, namely the bispecific antibodies. And we have already, I think, 3 bispecific antibodies approved in North America, in Europe. Of course, things can be different slightly from one country to another, but from a global perspective, I think 3 bispecific antibodies are already, I would say, on the track to be more and more widely used, namely elranatamab, directed against BCMA, teclistamab, directed against BCMA, and talquetamab, directed against GPRC5D. So I'd love to hear from both of you about the experience, for instance, with the bispecific, because these are the most frequently used these days. But of course, if you would like to share something about the antibody-drug conjugates, please don't hesitate. The challenges you're facing, complications, what is the feedback of the patient actually? And it's always very important to get this feedback if we want to improve things.
Yeah, so
I can
oh,
go ahead. No, you go ahead.
yeah, so we've had quite a bit of experience now. I think at the beginning, everyone obviously equated to toxicities the same as sort of CAR-T, and they had all these concerns around CRS and ICANS and all of these unusual side effects, which are sort of different to what they would have expect. So I think there's a lot of need still for nurses to be trained, and our staff who are not involved in research to have training on these, because they are so very different, the side effects. Reassuringly, though, obviously in the trials and previous trials, the toxicities have been less, of a higher grade as CAR-T, and we have seen that with our patients. They're not as sort of immediate and as generally as serious as that. But obviously, we take each patient very differently from one another. We assess it per patient, but a lot more education is needed in our area, I think, generally.
I agree. A lot of the nurses that were not it started off with clinical trials, so I got a lot of experience with it in the last, I don't know, 3-4 years with the bispecifics, and right now we do have it accessible in the teclistamab and the elranatamab, but the first doses have to be given in hospital, so the patients have to be admitted for observation, which I'm actually not against. I like that idea because we're giving it now to a lot of the elderly patients, and they are frail. And so I prefer to keep an eye on them, a closer eye on them, even though we haven't had their CRS, maybe 1 or 2, but never more than that. And we rarely saw any neurotoxicities. I mean, if we're waking a patient at midnight to ask them to write that sentence that they're supposed to write, then yeah, I would probably be confused too. So there are things like that. And I think the education is key here because they're going to give it out in the community. So those nurses, they were scared to give DARA 5 years ago. So this is the same idea. The more education, the better. And the patient needs to know the side effects, because some of them can be, especially with talquetamab, with the skin disorders like losing your nails and dysgeusia, not being able to taste your food, and weight loss is a big side effect with talquetamab.
So let's speak about the side effects. And I agree with both of you that maybe we are overemphasizing the issue of CRS and neurotoxicity, because thanks to the step-up dosing, whether with teclistamab or elranatamab, actually these are rather mild in terms of manifestations. And I think the pre-medications are really playing an important role in minimizing these side effects. But on the other hand, the use of these bispecific antibodies, especially teclistamab and elranatamab, targeting BCMA, which is a key molecule expressed on normal plasma cells also, not only the malignant plasma cell, is leading to a sort of a T cell exhaustion. And at the end of the day, these T cells are not doing any more their job, especially when it comes to protecting, from viruses. And we see some of these reactivation. And I think earlier, you, Anna, mentioned the issue of the need to give regularly immunoglobulins, and they can be given IV, subcutaneous. So what is the burden of the fact that you need to give frequently these immunoglobulins to minimize the infectious complications?
Yeah, so for the patients, it's another trip to the clinic, and they just don't feel good. They feel like they always have a sinus congestion or some sort of infection that they can't, or flu-like symptoms that they can't seem to get rid of. The IVIG does help. It helps keep their neutrophils up. It does help the virus to become a bacteria. So that's what we try to communicate to the patients. So we have a sort of a scale. So if your immunoglobulin G is lower than 4, we would start the IVIG. We usually start with IVIG and sub-Q comes later. And then when it gets to, because we were giving it always every 4 weeks, now our doctors are kind of increasing the frequency. So if it goes above 10 or 12, the IgG, then they'll go to every 6 weeks or every 8 weeks. During the winter months, they still like to give it every 4. But during the summer, I even had one of our doctors that didn't give it for 3 months, just to say, well, let's see if that helps the patient. If the IgG goes down, we'll restart it. So we're playing with that right now because yeah, it's just that extra trip again. It's the quality of life that comes into it again, that plays into it.
I think as well,
especially that winter time can be
Yeah,
quite long in Alberta.
and especially here. Yeah, well, we're not at minus 30 yet. Today's a beautiful day.
Emma?
I think as well, I was just going to say that I think we've only just seen the start of the issues around immunoglobulins and that therapy. We've only treated, quite a small number on trial with bispecifics at the minute here in Cardiff. But I think that that is another issue for our patients, which will get bigger as we recruit more patients. But yeah, like you say, they're never free from us and from our care, really.
So from a practical point of view, so all of these bispecifics, at least the approved ones, there may be bispecifics under development which are to be given IV. So for the time being, they are subcutaneous. But for instance, teclistamab is per body weight. So depending, so you have to adjust and decide on what you give. Elranatamab is a fixed dose. What are, in your practice, the pro and con? I'm not talking about efficacy or safety, just the practicality of having these two forms. Obviously, ideally, I'd love always to have everything accessible and then I can make my choice. But from a nursing perspective, are there any positive and pluses and minuses there?
We only gave it sub-Q. The only one we
Yes.
gave IV was cevostamab, but otherwise everything else is sub-Q.
No, my question is about the fixed dose versus the dose per body weight.
Oh, okay, yeah.
Because one is to be adjusted per body weight, so you have to calculate and prepare the syringe. And the other one is a fixed dose to everybody. Is this something of importance to you in your daily practice?
I think it's important with keeping close connections with the clinical team and the day units and education of day unit staff to give, to pick up on any changes within the patient's status, because we don't always see the patient every visit, for on a trial. So I think it's education, again, more education for staff about the importance of monitoring their body weight and you know, making those changes quite timely for the patient.
Wonderful.
We actually have a scale. So if they lose 10% of their body weight, that's when the dose would change. Even though we weigh our patients at each visit. If it's 10% less than the baseline, that's when the dose changes.
Okay.
And our pharmacy does that.
And for instance, are you allowed to, or maybe this is a question maybe for the pharmacist, I'm not sure you have the information, whether the pharmacists are using the same vial, you know, for different patients trying to avoid wasting product?
It's one. No,
It would be
one
one,
vial,
yeah.
one
Okay.
per patient. It's never, yeah.
They don't.
We never share. No.
No.
Okay, but in that case, I would guess having something which is a fixed dose, irrespective of the body weight, can have some added value, isn't it?
I guess, yeah.
Okay. No, I think
I think they tried the fixed dose with talquetamab. I remember being on that, doing one of the trials where it was a fixed dose, and then the trial was pulled.
I think
So
the development stopped, and that's also the case. I think ranatamab has a fixed dose, and teclistamab is per body weight.
Yes.
So I think it has been really a lovely discussion. We're reaching 45 minutes past hours. But I have really enjoyed it. I have learned a lot from you, and it's quite exciting to share the different experience from different places, you know, Alberta versus Wales. I think this is a lovely opportunity. Thank you for your time. Thank you for sharing your experience with our audience. I'd like to thank the participant for their very active participation, lots of questions actually. And you did a great, Anna and Emma. And I hope we will see you all in another ICH activity. Please don't forget that this webinar will be available on demand on the ICH platform, and it's very easy, ich.org. And then you can go there. Please don't forget that you can, in general, on the platform, claim your CME points, especially for those who need CME points. But of course, you have to answer some test questions. As for now, I would like to say thank you again for everybody. Thanks, Emma. Thanks, Anna. And I think we are going to meet tomorrow for another ICH activity. It's going to be a very fascinating journal club. Thank you and take care.
Thank you.
Thank you very much.
Bye-bye.
Bye.